Good morning, St. Louis. Erev Tov, Tiberius, and greetings to friends of Israel from around America and around the world. My name's Wayne Firestone. I'm the executive director of the America-Israel Friendship League. Twice a week for the past 16 months, we've been together on these webinars, keeping each other company, providing support for one another, learning from one another, and exploring the common values and the common issues that our two great countries are going through. It's stating the obvious that COVID brought us together, but it hasn't torn us apart. Thankfully, because of public servants like the panelists that we've assembled today, there are people who we've entrusted public health with in both Israel and the United States who have been working on the COVID issues in multiple capacities. And we have today brought together such a panel. We recognize it's not time for a victory lap. It's time for us to convene, assess some of the lessons learned, and recognize what in our own local communities we've learned and what it's going to mean going forward into the future. So we're grateful in this discussion, as in multiple discussions that we've had over the years, to have an absolutely terrific partner, the National Conference on State Legislatures, which in normal times is with us physically in Israel, as we've hosted delegations to Israel from many of the different states, if not all of the states and territories that are represented in the NCSL. We're grateful for their partnership throughout this webinar series. We're looking forward to hosting a future delegation in Israel when the health and safety and travel protocols allow us to do that. We continue to plan for that. I'm so grateful today to have Stacy Householder with us, who will make some opening remarks about today's panel and about our partnership and collaboration. Stacy's physically joining us today from Denver, where nearby she earned 2 degrees from the University of Colorado in Boulder, and she serves as the Director of Leadership and International Programs at NCSL. We also have on the panel today Representative Tim O'Neill from Southwest Pennsylvania. Tim is joining us in his capacity as a state legislator. We're so grateful to have you here. But so interesting, I've noticed in his background, after he has an MBA from the University of Pittsburgh and has private sector experience, but also comes to us as a veteran who was a captain and served in active duty in Afghanistan, and also a member of the Pennsylvania National Guard. I think it's, we may also tap on your experiences and perspectives from those experiences as well, and we're grateful to have Representative O'Neill today. And I also want to acknowledge our partners at the Ministry of Health in Israel, who work so hard to put together this program. We have with us today Adam Cutler, who also hails from the great state of Pennsylvania and is a University of Pennsylvania graduate himself, now living in Israel and having done his work, graduate work rather, at Bar Ilan University. We're grateful to have Adam here today, and he will be covering the perspective of the Ministry of Health from the International Relations Division. Just on the other side of town for me in Montgomery County, I am grateful to have Claire Hannon here, the Executive Director of the Association of Immunization Managers, which means that since 2004, Claire has been in contact with not only the 50 states, but also the territories, I believe 64 different independent entities, in looking at immunization programs. Claire, I don't know what prepared you for the past year and a half for the assignment that you had, but we're grateful to have your perspective of looking at this from the multiple jurisdictions. So let me start first now with Stacy, and to hear a little bit about how NCSL has related to this topic over the past year and a half, and we're so grateful for your help and partnership in putting together today's panel.
Well, thank you so much, Wayne. We certainly appreciate the partnership as well. Again, I'm Stacy Householder with NCSL. NCSL is a USA-based bipartisan organization that represents state legislators as well as legislative staff from all of the 50 states and territories. We provide in-depth research on topics from A to Z, professional development, and connections to help strengthen state legislatures in our federal system. A huge thank you to AIFL for partnering on this webinar. It's certainly been refreshing to have productive and important conversations with NCSL's international partners throughout the pandemic. And this topic is especially important as we begin to prepare for a successful post-pandemic period. The NCSL Health Program has followed the COVID-19 vaccine and public health efforts since the beginning of the pandemic. And in addition to responding to hundreds of research requests from around the country, NCSL has hosted webinars, podcasts, virtual convenings with US members from over 40 states, and produced timely publications. Plus, we have a robust database on state actions on COVID-19, which brings real-time information about bills in the 50 states. That's all on our website at ncsl.org. Almost 500 bills were introduced on the COVID-19 vaccine in states this year. NCSL's COVID-19 state legislation database includes all of these introduced and enacted legislation on these policy issues. Over the next several weeks, NCSL will release a vaccination policy toolkit for state lawmakers and a COVID-19 vaccine infrastructure and access policy snapshot. To take a look for those. We're excited to highlight the U.S. approach today while engaging in valuable conversations with the Israeli experts. Thank you so much for joining us, and thanks AIFL for this partnership.
Thank you, Stacy. And I see in the chat that we have people calling in from Denver, Colorado, Wheat Ridge, Colorado, Jackson, Mississippi, Washington, D.C., White Plains, New York. Please let us know where you're calling from. Chances are that our first speaker, Claire, has talked to someone in your state who has been directly responsible for whether or not and how quickly you may have been able to get a shot in the arm over the past several weeks. And indeed, please don't don't send any complaints to her. But we are looking for an opportunity to learn about what this has looked like, and are grateful, Claire, to have you as sort of kick this off and give us a perspective of what it's looked like and indeed some of the initial lessons learned.
Sure. Thanks very much, Wayne. Yeah, if you have complaints, just send them to Wayne. So I'm Claire Hannon. I am Executive Director of the Association of Immunization Managers, and our members are in the state public health agencies, also in the territories. 8 territories are federated states, and then there are 6 large cities that have directly funded immunization programs. So mostly state public health agencies, but they have been obviously very involved in the COVID-19 vaccine planning, the campaign, and then making it happen. So I have some slides to just give an overview of where we are and how kind of successes and how we've gotten here. And so I don't know if it's just, is it just me? Yeah, okay, good, thanks. So this is the CDC COVID data tracker. And you can find it's updated every day. You can find where we are in the nation as far as vaccination on any day. And right now, this is as of June 21st, we have administered more than 317 million shots. We have fully vaccinated almost 150 million people in the US. 53% of the total US population have received at least 1 dose. And around 7 million adolescents, 12 to 17, have been vaccinated with one dose. And I think what's been the biggest accomplishment is when you look at the population greater than 65 years of age, and 87% have at least one dose, and 77% of 65 and older adults in the US are fully vaccinated. Next slide. So just a little background, a reminder, if you're not aware, that the vaccine, the public health infrastructure, the way that we give immunizations here it's a public health system that is state-based. And so the data, our tracking, our strategies, our immunization information system that looks at uptake rates, these are all state-based. So every state has their own way of doing this, their own data system, doesn't necessarily share data across states. And it was a real challenge to put together that national data collection system. Our health system is private sector based. So the majority of our adult vaccines are given in the private sector, in a physician office, in a pharmacy. We did not previously have a sort of database of private providers who could receive a government supplied vaccine. So we had to build that. We do have a public vaccine program for children, the Vaccines for Children program, and that's really what we based our COVID response on. We have pediatricians enrolled to give children's vaccines, and that's been a success. And so we just expanded that for the COVID vaccine program. And I just wanted to also mention that funding for public health has been pretty stagnant over the last 10 or so years, and the public health workforce entering the pandemic was less than the workforce in 2009 that we had with the H1N1 pandemic. So there have been challenges, across the states with funding and public health workforce. Next slide. So some of our approaches and our successes. So we did the CDC did set up the CDC COVID tracker, a clearinghouse that states were reporting data within 24 to 72 hours, retail pharmacies reporting data on doses administered. And then they also have a system giving allocation of vaccine and data on where the vaccine's going back to the states. So that system was set up. It's not perfect, it's working very well. And again, setting up this basically infrastructure of private providers. Each state enrolling thousands of private providers, getting them to sign an agreement to store the vaccine properly, to report data, getting that network set up. The mass vaccination efforts, plus a focus on equity. So I think that's been really critical to our success, is that we did roll the vaccine out in phases, and the first phase in limited supply was focused on healthcare workers. We learned from that approach that it wasn't quite as efficient. We weren't getting vaccine into arms as quickly as possible. And that's really when mass vaccination efforts were put together. So large scale, high throughput clinics where we have better control of the vaccine, the allocation, the inventory. But also focusing on equity. So not forgetting to go into smaller communities, to get the vaccine into small pharmacies, using other providers as well to make sure that we're making the vaccine as accessible as possible. A large scale effort to address vaccine hesitancy, to anticipate it, state, local, and national campaigns, providing information, trusted resources, working with trusted community leaders, being transparent, making as much information as possible, as well as making the vaccine as accessible as possible. There were specific efforts to target hard to reach populations, very successful with those over 65, a large federal program enrolling retail pharmacies to reach those in nursing homes, and states having specific programs, many using the National Guard, their EMS to reach homebound seniors, to identify communities, people with disabilities, and going and taking the vaccine to them. And then the last thing I just wanted to emphasize again is that our states are very diverse. So this was a state-based approach, and it really differed across states. Some had a top-down, centralized approach We had others with a decentralized approach, county by county, some using pre-registration systems, some using no registration systems, some redistributing the vaccine. It's a large package of vaccine, some redistributing in smaller amounts to smaller providers, others using really large scale providers and sites. Some taking an age-based approach over phases, and others focusing on essential workers first. So we really, and a lot of people ask me, well, who was doing things right? Who was more successful? We did have some states get vaccine out more quickly in the beginning. And we've had other states, come have very strong campaigns since then. And so, it's hard to know. We are looking and exploring, exactly strategies that worked. Next slide. So just to show where we are, we do have the 70% goal, reaching 1 dose in all adults, 70% of adults by July 4th. And where we are with that, we have 17 states that have reached the goal of 70%. We have another 31 states that are between 50% and 70%. And then we have 4 states that are less than 50%. And I think you can see there the real, diversity across states. Vermont at 85% of their population with 1 dose, Mississippi at 45%. Next slide, I just want to give you a sense of some of the reasons behind that. And this is a vaccine hesitancy slide. And you can see just the real diversity of acceptance of the vaccine across states and across regions. The darker the region, the higher the percentage of people who are saying they will not take the vaccine. And so, posing some real challenges in the South and the upper Midwest to reach that 70% goal. And we're really doing everything we can to get trusted sources, faith-based communities, rural leaders, community leaders in rural areas, providing sound information, even going door to door in Alaska, other communities, to make sure people understand the value of the vaccine and are able to get it if they want it. And those are my slides. That's a general overview. Happy to answer questions, and really curious to hear from Israel and all of you.
Claire, thanks so much for that overview and really also the breakdown that you just showed on the different states. Obviously, we have people calling in from lots of different places. So I think how you experience your immunization experience, as you said, is very much dependent on where you are in the country and your neighbors and this next round. I recently had someone come knock on the door, and it's clear that this next stage of getting more people is presents both challenges and potentially the need for new strategies. So Adam, I want to before we dig down on a particular state example with Pennsylvania, Adam, I think it would be helpful, obviously, as somewhat of a contrast to Claire's presentation. Give us a bit of an overview of what the immunization program has looked like in Israel. You have one big district to deal with, and give us that overview. And again, I realize that as we speak, the issues continue to confront the health ministry in terms of how to maintain safety for the public. So we'd love to hear your updates on that as well.
Thank you, Wayne, and thank you, Claire. I'll just preface my remarks with Wayne has asked me to condense 1.5 years of COVID into a 5-minute presentation. So I'll do my best. I may have to leave some details out. First of all, important to note the difference in the health system here in Israel. We have universal health care here since 1995 with 4 HMOs covering the entire population. Basically what that means is that every person has an HMO that is responsible for their care. It creates a very different relationship it means we have complete coverage and someone who has to pay for it if that resident gets sick. So it's meant that there's been a lot more connection between the patient and the caregiver throughout this period. These HMOs cover the entire geography of Israel and compete with each other. And they're linked through national information systems, which have really aided our efforts in infection surveillance as well as vaccine rollout. Like many places, Israel's experienced 3 waves of COVID and 3 lockdowns. Our exits from these lockdowns differed, but in each lockdown release, attempts were made to create sort of a staged, gradual exit. And that, I think, was really the key to where we were able to succeed in creating that gradual exit. Where we exited more quickly, we saw the infection rebound quickly as well. We did experience fatigue over the restrictions by the population, and enforcement, particularly when lockdowns were less black and white, shall you say, enforcement was more difficult, the more exceptions that we introduced into the lockdown. In general, following the first lockdown, we got a little overconfident. We experienced a release that was perhaps too quick, and in terms of both reopening as well as reopening travel, and we saw that led to subsequent waves of infection. Our vaccine drive was among the first and most comprehensive globally. At its peak, we were vaccinating 250,000 people a day, and that's for a population of 9.25 million residents. Today, we've vaccinated over 5.1 million residents with over 10.6 million doses administered, and eligibility is open for everyone over the age of 12, including recovered patients. I think it's important to note how fortunate we were to be selected as a pilot rollout program by Pfizer and to be prioritized with the supply of vaccines. This was, I think, due to our small size, first of all. We presented a good case study for Pfizer in terms of rolling out the vaccine, our logistical preparedness, as well as our digital integration, which not only meant that we could reach out proactively to eligible recipients of the vaccine, but it also meant that we could collect data on safety and side effects and relay that statistical data back to the company. We work closely with Pfizer to pioneer new rollout practices and conquer new challenges. And this really was a first for the world in terms of rolling out the mRNA vaccine. Our principles for the rollout were speed, simplicity, and safety. One thing I want to draw attention to was our prioritization system, which was almost exclusively age-based. We did this for simplicity. We did this to ensure clear communication and that everyone knew when their turn would come. And it really took a huge burden off of our caregivers in terms of deciding based on medical condition who should be prioritized. That's not a decision we wanted to put on our caregivers, and certainly not a burden in a time of pandemic that we wanted to put on them. So we based it on age, and we think it created a good momentum to our vaccine centers that carried through a great deal of the rollout. We vaccinated primarily through our HMOs. This meant that patients were used to receiving their care through these channels. They could book their appointment through the same appointment where they would book their pediatrician, the same booking system. It meant the HMOs already had the contact information of the people they were responsible for. They were able to reach out by SMS, by email, by robocall, and say to their community, push 1, click this link, book your double appointment. And in some cases, the vaccine was even available at their local clinic, although we did open specialized centers as well. We focused on avoiding waste, enabling even those who were not eligible to receive the vaccine to line up at the end of the day. And if there were leftover doses, we certainly didn't want to see those doses go to waste. That was, in fact, how we vaccinated the vast majority of our first responders. While we were still prioritizing medical workers and the very elderly, we enabled our first responders to soak up leftover doses by acting as a standby vaccinator group. So when we had a vaccine center that had leftover doses, we'd call up the fire service and ask them to send over a certain number of firemen and firewomen to receive their doses. We were vaccinating, okay, so we focused on avoiding waste. We worked for solutions to nursing homes. We set up pop-up clinics in nursing homes to ensure that the residents, as well as the people who work there, were vaccinated very early on. We opened call centers to reduce medical errors and answer questions of vaccinated professionals, as well as a separate call center to reassure the public and answer patient questions. We worked to develop means of transporting smaller numbers of vials and later even single doses to reach those places that couldn't use the original 1,000-dose case. This was really pioneering work, but not high tech. We needed to work to ensure that vaccines would not be destroyed based on a break in the cold storage chain or due to the vibration sensitivities of the doses. So we worked closely with Pfizer to develop those solutions. We trained EMTs and paramedics to expand our vaccinator force. We used technology to reach out to patients, book appointments, plan supply levels for clinics, and document vaccinations on a national vaccine registry. We focused on encouraging vaccine compliance through proactive measures, such as reaching out to patients, through work with influencers. Our Prime Minister was the first to be vaccinated on national television, but we also very much looked at our medical community as influencers. And with high vaccine uptake in the medical community, we reassured the public. We created momentum by prioritizing large numbers of people. To be honest, at the start, I think we were prioritizing more people than we had doses. But that created the momentum and a lot of national pride that carried through the vaccine rollout. We had task forces embedded in our National Emergency Center, each responsible for a different minority community to ensure that none of these communities were left behind. I think that was critical. While every community is different, the fact that you have a team advocating for resources, advocating for methods of communication and outreach, and really serving as a voice for those communities within the National Emergency Center was absolutely critical. We had a flexible distribution system that shifted as demand shifted. We started vaccinating our medical professionals and the very elderly in hospitals. We very quickly shifted towards local clinics and mega centers in stadiums and shopping malls. And from there, we shifted to pop-up clinics and community-based centers at places of employment, academic centers, and municipal-based outreach. We created a domestic green pass system to enable our businesses to reopen and expand capacity in a safe manner, and really to reassure people that they could come out and patronize these businesses and know that they were in a safe environment. And we've already rolled back this program as our vaccination levels rose and our infection levels dropped. We created an international vaccine certificate to enable travelers to demonstrate their vaccine status abroad, enabling families to reunite after long separations. And today we're experiencing a small but significant uptick in infection as the Delta variant has spread among some unvaccinated school children. This puts a spotlight on two areas that I'll conclude with. Areas of increased risk as we roll back restrictions. I should note that Israel at this stage has even revoked the mask requirement, although we're considering reinstating it. The first area is travel. It's a primary vector where variants of concern can be introduced to the country, and we need to think about the systems we have in place to ensure that that doesn't happen or to minimize it. And the second is that regardless of vaccine levels, as long as young children are not being vaccinated, we can't reach true herd immunity. And those young people, and particularly the school environment, represents an environment where infection can spread. We're kicking up our eligibility. We had already opened it for over 12s, but we had not recommended it at first. This week, we've begun to put more emphasis on ensuring that over 12s are vaccinated. They're our group that is at the lowest levels at this stage. And expanding that even lower, I think, will prove critical to ensure that small outbreaks like this are down quickly. That's it from my end, and I'm happy to answer any questions and hear any comments.
Okay, Adam, you took the charge and you got an awful lot in there. We'll look forward to unpacking some of that in a moment. Representative O'Neill, I guess I noticed in Claire's chart, Pennsylvania was up there among the top performers, 74%. What have you seen? What's working in your state, and specifically from a legislative perspective, what have you and your colleagues been able to do at the state level that has informed the response and it at least led in this initial wave to some positive outcomes?
Yeah, well, thanks, Wayne, and good afternoon or maybe even good morning to some of you still. I certainly appreciate the opportunity to be here with you today. Really, as COVID-19 vaccines begin to be distributed throughout the United States back in late December, early January, quite literally, Pennsylvania was not doing a very good job in the initial rollout. We were actually ranked, from a national standpoint, we were ranked near the bottom of all states in the administration of the vaccine. And in addition, we discovered that the leader of the organization put in charge of vaccines for Philadelphia had injected 4 of his friends who weren't eligible. Some unqualified people were administering the vaccine at the Philadelphia Convention Center. The residents of Pennsylvania were extremely frustrated in the onset of the distribution. Our initial rollout was not well received, well managed at all. It was a completely decentralized system that just simply wasn't working for the Commonwealth. Additionally, late January, Pennsylvania actually expanded eligibility for the initial phase, making appointments for the supply constraint vaccine to begin with extremely scarce, and that was even amongst our most vulnerable residents. So amid this frustration, I actually had the opportunity to draft legislation to have the Pennsylvania National Guard assist with the distribution and administration of the vaccines throughout the Commonwealth. Wayne mentioned it in the introduction, but as I've previous experience as a National Guardman in Pennsylvania, so I knew firsthand the mission-focused, good work that our Guard does, obviously both home and abroad. And our military deploys millions of dollars worth of equipment, thousands of people across the world in a timely and efficient manner. And there wasn't any reason why they couldn't use their logistical expertise at home when it comes to the COVID-19 vaccine efforts. It's a perfect group, in my opinion, to help facilitate getting the vaccines into arms. So amazingly from introduction to signature by the governor, making my proposal into law was just shy of 5 weeks from start to finish. And truthfully, anybody familiar with Pennsylvania legislative process knows that type of speed does not occur very, very regularly. But I think it's also a testament to just how dire the situation was in the Commonwealth, and how really all parties involved realized that the situation needed to change and needed to change quickly. In addition to that, just off the hills of my legislation being signed into law, the governor agreed in early February, the governor agreed to create a COVID-19 vaccine task force with leaders from both the executive and legislative branches. And I was honored to be appointed to represent the House Republican Party on the task force. Immediately upon formation, the task force began to meet and began to discuss issues along the distribution and administration of the vaccines. We discussed everything from communication efforts to the provider network. As I mentioned earlier, with a decentralized system, we literally had 3,000 various suppliers or providers across the Commonwealth that were signing up to be eligible to give the shots. And it was a situation that was simply unmanageable. So we immediately got into those issues, and before the end of February, the Pennsylvania Department of Health actually issued an order directing partnerships between the state's hospital systems and counties to create vaccination sites. By early March, we unveiled a special initiative to get teachers vaccinated so schools could reopen effectively and confidently. We used what became my legislation that became Act 4 of 2021 to allow the National Guard to assist with this work. My wife is actually an educator, and she was involved in this initiative, and the National Guard medic gave her vaccine. I personally was administered a vaccine with the National Guard as well. Once education professionals were vaccinated, we directed counties to establish regional vaccine clinics. We then targeted frontline workers and first responders, those that hadn't had the opportunity at that point. And finally, on March 31st, we announced an accelerated vaccination timeline so that all Pennsylvania adults would be eligible to receive their vaccine by April 19th. And one of the things that I'm very proud of our work on the task force is, as we sit here today, Pennsylvania really, and you mentioned it, Wayne, as far as Pennsylvania being in the green category of that chart, Pennsylvania is now a leader at getting shots into arms in the nation. As of yesterday, 88.07% of the vaccines that the Commonwealth has received have been distributed and administered. And 62% of Pennsylvania's population have 62% of entire population at this point has received at least our first dose. And that includes children, those 12 and older. This ranks Pennsylvania 8th among all states for first dose administration by percentage of population, and really it's indicative. Out of the 10 largest states in the in the country, which Pennsylvania is amongst that group, we have been leading the nation amongst the group of our peer states. So it's really a testament to the success of the task force, and certainly those that have followed Pennsylvania, and certainly Pennsylvania politics throughout the course of the COVID pandemic, certainly knows that the responses of government, the way we've approached things, the various things, the lockdowns, the business closures, the mask mandates during the course of the last year, 15 months, has been very divisive across the Commonwealth. I think Claire mentioned earlier that we are a very diverse nation, and that is certainly true, but we see it even amongst the state of Pennsylvania. We are a very diverse state. And there's been much disagreement over the course of the last year on how to handle the various aspects of the pandemic. So for that reason, I will admit that even as I was appointed to the task force, I was very skeptical of the task force itself and whether or not it was going to be worthwhile. But our success, I think, really shows how much can be accomplished when all political parties and viewpoints come to the table. We have the ability to check our egos and quite literally work towards a common goal, because there's been no bigger topic, obviously, as we all know, for the last year, and certainly as the vaccines have come online, there's been no bigger topic to address and an issue to address amongst specifically Pennsylvania than making sure the vaccine was available for every single person who wants it. I'm happy to report that we are in that situation now. Many of the things that Claire highlighted around hesitancy is certainly things that we focused on the past several months, dealing with the task force itself, it is, as well as the 2 points of mass vaccinations, as well as focusing on that equity piece as well. So I'm happy to be here, happy to answer any questions, and thank you very much.
That's so helpful. Claire, I feel like if we were in I don't know, in your MPA program at Johns Hopkins, they must be, that you graduated from today, they must be looking at the case study. And this would be a classic example of a centralized approach versus a very decentralized approach. And I'm wondering from your perspective, what you might be able to share of what you've seen up until now that we see, as we move forward in addressing, the continuing challenges. Do you see a role for the federal government that will have to supersede the role of states in some cases, or is there enough of an infrastructure now in a decentralized approach where there's information sharing and there's the ability to pass on information in a way that will protect everybody's public health? Well, I think did we lose Claire for a moment? It looked like she may have dropped off. I'll come back to that. Adam, I'm going to come back to you for a moment while we're waiting on Claire. How, there's something Representative O'Neill said about speed and the ability to pass legislation quickly, the ability to make pivots when something isn't working. From your presentation, that certainly seemed to be critical and even really underpinning the Israeli experience. Now that you have woken up to the reality of new numbers with the Delta variant, how much what do you expect the rest of the summer to look like in terms of potentially the new restrictions and guidelines that you may have to issue?
Well, I mean, that's a very political question at this stage. We've just changed governments. There are going to be some policy shifts as a result of that. We're seeing an upswing in infection, although still low numbers at this stage. I think it's likely that we'll reconsider reinstating the mask requirement indoors, particularly for schools. I think the big question right now is when we'll reopen for tourism. At this stage, travel is still closed to non-Israelis to enter Israel, with about 24 exceptional cases. And there's a question about delaying that another month. At the end of the day, the ministers are going to have to come together and decide what they can live with and what they think will be the most effective. And we're still in that decision-making process. This recent uptick is only a couple days old.
Indeed. Representative O'Neill, I wanted to come back to you on you mentioned the issue of hesitancy, and one of our viewers has already written in, someone from New Jersey asking about, okay, I've been a good boy. I've been following the procedures up until now. I've actually been on the cautious side of this. What are you hearing and seeing from people who were saying they just won't do it, and particularly in rural areas where we saw on the map there appear to be some additional challenges.
Yeah. So what we're seeing is hesitancy. There's actually a wide range of what we might refer to as hesitancy, and you here in Pennsylvania, we are absolutely going to continue to have a small segment of our population that absolutely refuses to get the shot and to ever get the shot, and that's the reality, and that's the way I personally look at it is that's their choice. I think the larger majority of those that have been hesitant are really taking a wait and see type approach, with the newness of, and quite literally some of the misinformation out there about exactly what the vaccines are, what they do. I think there is a large majority of people that have yet to get the shot that they're not dead set against getting the shot. They're just they're taking more of a cautious approach as far as let's wait and see. Let's let the science come out a little bit more. Here in the United States, we still, as many people probably know, the vaccines are still under emergency use authorization. They have yet to get full authorization by the FDA. So many people are waiting for that next step because there's still that hesitancy of whether it's safe, what the long-term effects are, which obviously with the novelty of it, we just don't know, or we don't have a wonderful understanding of that yet. So I really do believe there is a large segment of those that are hesitant that are still persuadable, whether that's through time or through messaging, through, as Claire mentioned, trusted partners. That campaign of attempting to educate people more thoroughly is absolutely happening across the Commonwealth. And we've here in Pennsylvania, we've taken really a more specific approach based on the various hesitant type groups. So there's a campaign specifically geared towards educating and addressing hesitancy amongst the African American population across the Commonwealth. One big group that we see hesitancy in across the Commonwealth is actually conservatives. So there's a campaign specifically around attempting to educate conservatives on hesitancy. So we are definitely taking the approach here in the Commonwealth. We have absolutely taken the approach that it is still there are not mandates in any capacity at this point. Some private entities have gone down that route. Government has not. And that's the approach I support as well. But I think most people really are taking that wait and see approach as opposed to the approach that they're never going to do it. So.
Well, that's both helpful and encouraging. Claire, I think we solved the connectivity issue. If we have you, I don't know if you either want to piggyback off of the last response, the last issue we were dealing with is the people we haven't reached yet, and are there things that we can and should be doing or have learned that might help on the hesitancy issue. And then I don't know how much you heard of my earlier question was about the federal versus state responses. How centralized or decentralized going forward do you see are there specific roles that should be more centralized in terms of the overall immunization and vaccination program? I'm just curious, in listening to the Israel experience, where you sort of see things going in the future.
Yeah, well, first of all, can you hear me?
Yes.
Okay, good. I'm sorry, I don't know what, my laptop went out, so I switched to my other computer. So I mean, I agree with everything that Representative O'Neill said. I think there is a certain percentage of the population that still will get the vaccine. We just need to continuously work to be open and educate them, provide open information, and make sure the vaccine is accessible to them. As far as the federal government, the centralized approach, I do think it was very successful to have the allocation system come centrally, and the distribution system was more on a local basis run by each state. And I think that even though we've never really done that on a large scale before, the government purchasing the vaccine, investing in the vaccine, and then allocating the vaccine state by state in a centralized way, I think that was very successful. The other thing that was done in a central way was reaching the nursing homes and the retail pharmacy program. Rather than having them enroll in every single state, they enrolled one time with the federal government. And I think that proved to be much more efficient than what we did in 2009. Pharmacies were enrolling in their state. And so I think that was successful. Looking forward, I really like what Israel talked about with using their HMOs, using their health systems. A lot of our health systems cut across states. And so it was really tricky for them to enroll in different states as providers, their scheduling system to connect it with different states. Some states having different priorities, different groups they were focusing on, made it very difficult for large health systems to do something in a way. So I think that moving forward, if, we can do that in a more centralized way, I think that would be helpful. I mentioned the data challenges, and having a centralized data system is, it's very difficult, and we want to make sure that we ensure privacy and freedom. And so having that centralized data system presented challenges, but I think we made real strides in connecting the system we have, and we really need to have a national network of connected data systems. And so that's what we're looking at moving forward. I do think that the decentralized approach, Representative Neal talked about that in Pennsylvania. We did that in Maryland as well, and we really struggled initially. And I think that's a lesson learned. At the same time, I think the reason that they did that in Maryland is they did not want a single system that might fail. So especially around data and IT and scheduling and registration. But I think that was really lessons learned. Those states that took a centralized approach in the beginning, Alaska, West Virginia, North Dakota, they were more efficient in the beginning. So I think somewhere in there is a balance where, we have to have that centralized efficiency, but at the same time, for trust and diversity, everything really does come down to local when you're talking about people believing in the vaccine and going to get it.
Representative O'Neill, I want to come back to you on one of those issues that we heard on a prior webinar. We had superintendents of different education systems talking about having different rules even within the school system in different counties or even in the same county, et cetera. And your reference to you're having a household expert on the importance of getting this right. What do you think at the legislative level is likely to happen as we think about the coming school year and bringing together challenges of public health with challenges of public education? How do you see that? What do you think the coming school year might look like, at least in your district?
Yeah, so it's an excellent question, and certainly something that has been talked about quite a bit here in Harrisburg. We're actually within our budget week right now in Harrisburg, so this is the busiest time of year, and certainly these conversations are happening right now. I think we found out through the course of the pandemic that as we experience this, and it's interesting that Adam's comments talked about spread amongst school-age children, but I think there is really a focus here in Pennsylvania that the decisions on exactly how to operate each individual school district, because we're such a diverse Commonwealth, they really should be made at the local level within the administration of the school district. The state level can provide guidance. We could provide resources, but I think we need to err on the side, and these are the discussions that are happening. We need to err on the side of having children in the classroom. We've seen huge drop-offs in education rates and participation and learning challenges from the 100% remote learning, the shutdown of schools. And I think at this stage in the pandemic, with the rollout of vaccine, especially now all the way down to age 12, we really need to allow local communities to manage the situation that they're seeing on the ground. In the event that we have a public health emergency in a particular school district or a particular community, I think we need to, here at the state level, provide those resources to go in and help that community where the rest of the communities and the school districts across the Commonwealth remain and operate in a relatively normal fashion. That may vary, based on the area and the time and the situation on the ground in the moment. But I think we've learned really the local level control is the way to go when it comes to educating children. We have over 500 public school districts in Pennsylvania, and there isn't any reason why a school district in my area can't be operating when case counts are very low, even if there is a flare up in a suburb of Philadelphia or what have you. So I think that'll be the focus of education policy in relation to the pandemic going forward. Obviously, we're going to continue to advocate for the vaccines as the situation changes, eligibility changes, allow parents to make those decisions for their children, and ensure that we get as many students in the classroom as possible while managing those issues.
Great. Adam, I'm going to combine a couple questions here. We have somewhat unrelated on the hesitancy issue. People want to know, has there been progress made with the ultra-Orthodox community, which seems to be one big area? Maybe there are others in Israel by groups that you could refer to. And secondly, there was a unrelated question about prisons and whether that has been prioritized and where they are in terms of being able to prevent additional breakouts.
Of course. First of all, on hesitancy, I just want to relate to something that Representative O'Neill and Claire had mentioned, which is the distributed systems and as it relates to hesitancy. We had a lot of momentum at the beginning of our rollout, but we also saw very early on high levels of hesitancy, which dropped off within a week at really high levels. It's an open question as to why that happened, but I think it's because we started with such a high level of momentum that very early on people knew other people in their lives who had received the vaccine, and that level of confidence went down very quickly. What we see now, we went with that momentum for a long time, and what we saw later in the vaccine rollout was more difficulty reaching people who were less motivated. And that goes straight to the point Claire made about accessibility. And this links in with distributed systems, because what we realized was it was the local communities that knew how to reach these people, how to make the vaccine accessible to them. And we were reaching out to municipalities, to employers, to academic institutions, and telling them, organize a group of 100 people who are willing to receive the vaccine, and we'll create a pop clinic and vaccinate them all in one go. Tell them they can bring their families, whatever it is. these were the places where people were, where we made it convenient for them and accessible, and we managed to prolong that momentum longer. As relates to minority communities, we're looking at them individually as we monitor infection, but we're seeing good vaccine rates and we're seeing low infection rates. The outbreaks that we're seeing now are not in those communities, and that's encouraging. As relates to the prisons, they were among the highest prioritized. There were a few very early on disputes at the ministerial level that may have delayed the rollout in prisons by a number of days, but you can count those on your hands. And we're very proud that we prioritize the prison community. It's a community that is at heightened risk because of the density of the living conditions in facilities like that.
Well, thanks. I have a long list of my own questions, as well as questions from the audience that we're not going to be able to get to, unfortunately, today. But a number of them relate to travel and new potential travel restrictions with Israel. But I do want to thank everyone, each and every one of you, and especially NCSL, for your continued work in bringing together the body of knowledge of state legislators in real time and during this crisis. And we so are appreciative of the expertise that exists at the local and state level that you've been able to muster and share in the context of your work and in our work over the course of this last year. It affects so many people, and we so relish this opportunity to bring together people who are working on this for the good of the public and have learned lessons, as we say, that may actually be shared and help one another as we're thinking about how to do this better, how to learn from the unexpected, as well as what we may actually be able to expect in the coming year. I do want to remind everyone a little bit of a program note. While we can't guarantee when you can get on a flight next to go visit these wonderful places in Israel, we are continuing with our monthly virtual tour program with Reuben Solomon, the master tour guide. We are going to the Galilee region again this week with a visit to Tzipori. If any of you have had the opportunity to visit and see those incredible mosaics, this is your opportunity, whether you've been there or not, to really explore that. We hope you'll join us on Sunday, as each week we explore different aspects of the relationship between friends in Israel and friends in the United States. Thanks, everyone. Thanks to our panelists and NCSL for being here with us today. Have a safe and healthy week and an enjoyable summer.